everyone, and welcome to the Integrative Nurse Coach Gathering webinar. I'm Carly Mertz. I am a registered nurse and board-certified nurse coach and proud host of tonight's webinar. Whether you're joining us live or watching the recording, we are so grateful to have you with us tonight. So tonight's presentation touches on a topic that is both timely and critical: mental health. As nurses, we see extreme levels of stress, anxiety, and depression in our patients, from adults to children. So as nurses and nurse coaches, we're uniquely positioned to offer hope, empowerment, and real solutions to support mental and emotional well-being. So that is why we are thrilled to welcome our expert guest, Dr. Bernadette Melnyk, who will be sharing about the COPE program, which stands for Creating Opportunities for Personal Empowerment. Dr. Melnyk is a nationally and internationally recognized leader in evidence-based practice, mental health, and wellness. She is the founder of COPE to Thrive and co-founder of EBPSolutions, and has served in influential roles, including Vice President for Health Promotion and Chief Wellness Officer at Ohio State University, the first role of its kind in higher education. Dr. Melnyk is the creator of the COPE Cognitive Behavioral Skills Building Program, now used in all 50 states and several countries to reduce anxiety, depression, and promote healthy behaviors. With over 600 publications, 10 edited books, and more than $36 million in research funding, she is also editor-in-chief of Worldviews of Evidence-Based Nursing and an elected fellow of the American Academy of Nursing and the National Academy of Medicine. Dr. Melnyk has held leadership roles with the U.S. Preventive Services Task Force, the National Institute for Nursing Research, and the National Forum for Heart Disease and Stroke Prevention. Her dedication to improving healthcare through research, education, and innovation continues to inspire healthcare providers around the world. So before we get started, let's do a little awareness practice to get settled. So everyone get comfy in your seats, and you can close or lower your eyes if you're able to. Gently release any tension you might be holding in your body. And let's take a few slow, intentional breaths together. So inhale deeply and exhale fully. Let's do that one more time. Inhale deeply and exhale fully. Feel yourself arriving in this moment, surrounded by a community of like-minded nurses dedicated to growth, healing, and expansion. And let's open our hearts and our minds to the new wisdom during this webinar. And a quick little reminder, please place all your questions in the Q&A box at the bottom of your screen, and we will leave time for discussion at the end of the presentation. And now I am thrilled to welcome Dr. Melnyk.
Thank you, Carly. I am so excited to be with all of you today. I am a staunch advocate for coaching and nurse coaching in particular. I am so grateful to all of you for all you do to promote the health and well-being of your clients. I want to first disclose my conflicts. As Carly mentioned, I am editor of 10 books. I am founder and owner of COPE to Thrive that disseminates my evidence-based COPE programs. Now also other versions available for adults, including pregnant, depressed, and anxious women, and cancer survivors and patients. So with that, I'm going to start with a dose of vitamin G to all of you. We have so much evidence to support the positive benefits of daily gratitude. So if we can get in the habit of we starting our day counting our blessings and encouraging our clients to do the same, they will experience positive mental health as well as cardiovascular benefits. Well, I'm going to share a bit of my personal story so you will totally understand why I am so passionate about mental health and the programs that I have developed and tested now in about 28 published studies. I grew up in a small coal mining town. You see it on the slide here, an hour south of Pittsburgh, right on the West Virginia border. Population, 1,000 people. My dad was the coal miner. We lived in half of a little company house. We struggled financially, but I was born with rose-colored glasses on. I can still make lemonade out of lemons any day. But when I was 15 years of age, home alone with my mother, she sneezed, stroked out, and died right in front of me. You can imagine how traumatic that would be for a teenager. I suffered from terrible post-traumatic stress disorder, anxiety, and depression. After about 5 months not sleeping through the night because of nightmares, not really functioning in school, I was taken to my family physician, and my family member said to the physician, "Please do something to help Bern." There was no gold standard evidence-based cognitive behavior therapy in my little rural coal mining town. No mental health counselors, but sadly, speed through to 2025, we still have terrible stigma. We still have less than 50% of people who are suffering from depression, anxiety, post-traumatic stress getting any treatment, let alone evidence-based treatment. Well, that provider did what so many still do today in 2025. Got out the prescription pad, wrote a script for Valium, said give Bern one of these every night. She'll sleep and she'll be just fine. Well, I remember taking a Valium that night. I woke up the next morning groggy. I didn't like how I felt. So I said, I don't want to take these anymore. I just got to gut it up and cope, which I did. But in the next 4 years, not only was I with my mom when she stroked out and died, but I then lost a cousin that was like a brother to me. after a motor vehicle accident. After that, I lost the only grandparent I ever knew and loved. And at age 19, my dad had his heart attack. Now, that's a lot of grief for a teenager. But you know the story. What doesn't break us only makes us stronger. And as a result of what I went through during my teenage years, I became passionate about becoming a nurse, then a pediatric nurse practitioner, a psych NP, and go on and get my PhD so I could develop evidence-based programs to improve mental health in children, teens, and young adults. Well, the saddest part of my mom's story, she had a history of headaches for over a year. And my dad kept saying, would you go to the doctors, figure out what's wrong? She went to her family physician just 1 week before she died. Her diagnosis, high blood pressure, given a prescription for a blood pressure medication that my dad found in her purse after she died. She never took it. But think about this. Behavior change is what I call character building. We spend more money on healthcare than any Western world country, but we rank in the bottom for population health outcomes. 60% of Americans and others globally have a chronic disease, but 80% of chronic disease, including mental health disorders, are preventable with just a few healthy lifestyle behaviors like physical activity, healthy eating, sleeping 7 hours a night, limiting alcohol, and practicing regular stress reduction. But sadly, we live in a sick care, crisis care, healthcare system. We need to flip that paradigm to one of wellness, prevention, behavior change, and mental health promotion. And that's your expertise, what you do a great job at. Well, before the pandemic, nearly 1 in 5 children, teens, and adults had a mental health problem, yet less than half receive any treatment. And we're living in an era right now where suicide is the second leading cause of death in 10 to 34-year-olds. In Colorado, suicide is now the leading cause of death in children and teens. So when March of 2020 struck, COVID-19 further triggered skyrocketing mental health problems and unhealthy lifestyle behaviors in children, in teens, and in adults. And because depression and anxiety escalated to 50 and 60% of its levels prior to the pandemic, many people turned to alcohol and drug use in order to regulate their emotions. This was a very interesting study that looked at 32 billion private healthcare claims from 2019 to 2020. In 13 to 22-year-olds, look at the skyrocketing rates. In 13 to 18 years of age, an increase in self-harm by 90%. Generalized anxiety disorder increased by almost 94%. Major depressive disorder increased by about 84%. So after the pandemic, where are we now? I think a lot of people thought we would nicely see drops in mental health issues, maybe prior to those we saw before the pandemic. But we have not. We are now in a mental health pandemic throughout the globe, as a large percentage of the population are struggling with depression and anxiety. Well, screening raises a red flag. Everybody at every visit should be screened for depression. When I was on the United States Preventive Services Task Force, our recommendation changed to screen all adolescents 12 to 18 and adults for major depressive disorder in primary care. But the second part of that USPSTF recommendation says screening should be implemented with adequate systems in place to ensure accurate diagnosis, effective treatment that includes gold standard cognitive behavior therapy or interpersonal psychotherapy, and appropriate follow-up. Now, over the past couple of decades, I have conducted so many national workshops for both nurse practitioners, school nurses, physicians, on how to better screen for and treat using evidence-based interventions for mental health disorders. One of the most common feedback statements that I hear from physicians in particular is, Bern, we don't screen because if we find, we have nobody to refer to. Our children, our teens, our young adults, often still in 2025, are waiting 2, 3, 4 months for an evaluation or for treatment. Screening for anxiety in children and teens aged 8 to 18 is now also recommended, and in adults, including pregnant and postpartum women. So there's a variety of free, valid, and reliable tools to screen for depression and anxiety. The PHQ-9 is such a beautiful, validated tool that can be completed in just a minute or two. There's also a PHQ-9 modified for teenagers. And for anybody who says that survey, the PHQ-9 is too long, now there is a PHQ-2. So it's just 2 items to screen for depression. The PHQ-3 adds item number 9, which asks about suicidal ideation. For younger children, the CESDC is a fabulous screen for depression. That scale is also free and in the public domain. And I gave you the websites where these instruments can be downloaded. Recommended screening tools for anxiety include the GAD-7, and like the PHQ-2, there is a GAD-2, 2 items that are valid screens for anxiety. For younger children, I really like the SCARED. It's a longer instrument. It's for 8 to 17-year-old children and teens, and it's available at no cost at the website on this slide. So if we pick up that somebody is depressed or anxious, it's really important to screen for suicide. Ask about ideation, a plan, and means. And it's really important to develop a safety plan. Pam Lusk and I have a practical guide to child and adolescent mental health screening, evidence-based assessment, intervention, and health promotion. In that guide, there are wonderful tools. There are screens for the whole variety of mental health issues. Everybody also, all of our clients need to know about 988, the Suicide and Crisis Lifeline. Somebody is there to support you 24 hours a day, 7 days a week. There are professionals that are non-English speakers as well. So I want to talk just a minute or two about the causes of depression. We all know there are various causes of depression, but a major root cause of depression is depressogenic cognition. That's negative patterns, automatic negative patterns of thinking. We have habituated to the way we think. Scientists have actually studied this. We, as adults, have an average of 6,200 automatic thoughts every single day that we don't even know we have anymore. Sadly, about 60 to 70% of those thoughts tend to be negative and cause us emotions of stress, anxiety, and depression. I am a psych NP. I had an independent practice with colleagues in upstate New York. We had children and teens who had been on so many medications. When you walked in, you were handed a chart about 4 inches thick. And it's like, where do I start? But these children and teens were on so many meds. Now, SSRIs, which are frequently, routinely given first line if you're diagnosed with depression, they only work for about 40% of people put on them. I've written SSRIs as a psych NP, as a PNP, but only for severe depression or anxiety. Because when somebody comes off an SSRI, even if it was working for them, they rebound about 70% of the time. Why? Because they haven't learned how to change their automatic negative thinking around to more positive thinking. We've got a large body of high quality research that says CBT is gold standard, first line, evidence-based treatment, and it works for both anxiety and depression. So first line, with anybody experiencing mild to moderate depression and or anxiety, first line, they should be started on CBT or CBTSkills building, which is what my co-programs are all about. If I'm into session 4 out of 7 of my program, and there are severe symptoms, then yes, it's appropriate to add an SSRI. Well, the science now shows that CBT establishes healthy neuronal connections when people practice the skills that are from CBT. And I don't know if you saw this recent study by Heller and colleagues, but they showed through their work CBT alters brain activity and improves anxiety symptoms. So now we have got physical proof, in addition to self-reported proof, that CBT really works. Many of you probably know I've been banging the evidence-based practice drum since the late 1990s. I was so hoping by 2020, EBP would be in the DNA of every nurse, nurse practitioner, physician. But sadly, my national studies show we have so much opportunity in front of us because only about 20 to maybe 30% of clinicians consistently implement best evidence-based practices. We joked about the 15-year time gap back to 2000, that it takes, 17 years, we always said in 2000 and beyond, to translate high quality research into the real world. But then it came out in 2021 by Kahn and colleagues, and they actually showed in 2 decades, we reduced the research practice time gap by 2 years. So at that rate, think about that. It will only take us 150 more years to translate evidence-based interventions rapidly into practice. The gap between what we know and what we do is lethal. So I want to share how I started to develop my COPE program. I was serving as a nurse practitioner consultant to the child and adolescent inpatient psychiatric unit at a inpatient psych hospital in upstate New York. We would admit children and teens from 5 to 17. They were often with us for months getting treated. They would go to school during the day. And when I first got there, I was responsible for doing admission histories, physical exams, GYN exams on the sexually active teens, as well as monitoring for medication side effects and treating any illness that happened on the unit. Well, after I was there for about a month, getting really oriented into the spectrum of care, I asked the psychiatrist, are the children and teens, do they get CBT? Not routinely, she said. And so I called the question, why don't we give these children and teens evidence-based CBT skills? Because this will prepare them for stress, anxiety, depression that they experience for the rest of their lives. So the wonderful psychiatrist that I practiced with said, Bern, if you want to do it, go ahead and do it. I talked to the teachers. I searched the literature, trying to find a manualized CBT program that I could use with teens. I came across one program. I tried it with the teens, but they lost interest immediately and it went over their head. So I said to myself, I got to create this CBT-based program that I can teach to the children and teens, and then I could study it, search. And that's how my COPE program started. CBT guides COPE. So the key concept again is the thinking, feeling, behaving triangle. How you think relates directly to how you feel and how you behave. These are all the components of effective CBT. I ended up specializing in CBT. So I thought, as both the PNP and PsychNP, if I could put all of these components of effective CBT in a workbook, in a manual, then I could even teach non-mental health providers how to deliver it. Teachers, nurses, social workers, a variety of health professionals. Then I said we could help so many more that aren't getting treatment. So my COPE 7-session program covers all of those key concepts in CBT. Thinking, feeling, behaving, what's the connection? Self-esteem, positive thinking, self-talk, stress and coping, problem solving, and setting goals, dealing with emotions in healthy ways, coping with stressful situations, developmentally tailored to younger children, to teens, to young adults, now to adults, pregnant women, and cancer patients and survivors. Well, each of these manualized sessions in my COPE program are followed by skills building activities, because if we don't help people to put into practice what they're learning from the sessions, their ability to make thought change is going to be drastically reduced. So the skills building sessions are such a key part of this program. And that's why every individual who goes through the COPE program also gets a workbook that they keep bringing back to sessions with them. I also have a 15-session COPE program that adds sessions on nutrition and physical activity, but it's got all the key elements of CBT in that program too. I am careful not to say this is pure CBT, because then you'd have to be certified to be able to deliver it. I call this program CBT Skills Building. So COPE teaches the ABC. A stands for an activator that triggers you to have a negative thought. You replace that negative thought or belief with a positive thought to feel better emotionally and to engage in healthy behaviors. So a concept that is strewn all the way through each of the COPE programs is catching, checking, and changing your automatic negative thoughts. Here's what I would encourage you to do for the next 30 days. When you feel yourself get angry, anxious, stressed, or depressed, I want you to stop and say to yourself, what was just going through my mind? Is that thought really true? Is this type of thinking helpful? And do I have evidence to back it up? 98% of the time, the answer's probably going to be no. That thought really isn't true. It's not helpful, and you don't have evidence to back it up. So I encourage you to then change that automatic negative thought around to a positive, to feel emotionally better. We also know through a lot of research that mindfulness integrative CBT really helps to prevent relapse. So all the way through COPE, we reinforce and teach mindfulness, how to stay in the present moment. Worry about the future, guilt about the past are the two most wasted emotions that we have. So if we can teach our people to be mindful in the present moment, they will experience so much less stress, anxiety, and depression. We know through research that self-affirmations work. So partly through the COPE program, one of the skills building activities is for people to write down 2 positive self-affirmations that actually are opposite of negative ones that they tend to say to themselves. For instance, if somebody flubs up at school or at work, we often label, we'll say, I'm stupid, or should statements we use all the time. I should be a better parent. I should be a better nurse, or whatever it is. But if we get up in the morning, when we brush our teeth, we put that positive self-affirmation there, say it 10 times, say it 10 times again at night, it really starts to reframe our negative thinking. We're having some technological glitches today. I had this fabulous video clip. This is a little girl who gets up every morning. She stands on her sink, looks in the mirror, and she says a ton of positive affirmations. Now, my whole house is great. I can do anything good. I like my school. I like my friends. I like my toys. I love my parents. I love my sisters. But it works. So I mentioned skills building activities. So this is one of the skills building activities that follow session 1. Name 3 situations in the past few days of how thinking, how you felt, and how you behaved. Now write down how you could have changed your thinking to feel better and act differently. There is also a weekly goal setting and self-monitoring log that everybody completes. They set a goal. They write 2 positive self-statements. They keep track how many times each day that they set them, and they rate their emotions. And what people do through the process, the 7 weekly sessions, 90% of the time, they're going to see through use of these skills. They're less worried, they're less stressed, they're happier, they're less sad. So I was really interested in how can people get reimbursed to deliver COPE in primary care so that nurse practitioners, physicians could deliver it and be rewarded through reimbursement for it. Once I figured that out, COPE started to scale like wildfire. Now it is used in all 50 states with reimbursement in primary care. That is a researcher's dream. So many researchers spend their whole life creating evidence-based programs that are never used in the real world. By my count now, over 200,000 children, teens, young adults, and adults have received my COPE program. People bill for it with 99214, and I published a cost analysis of COPE that showed for every hospitalization we prevent for depression, it saves the healthcare system over $14,000. So even if 10,000 children and teens who received the COPE program didn't get hospitalized for depression, we would save our US healthcare system $146 million. Well, COPE is spreading now globally, which I am so excited about. It's in Canada, the UK, Australia, South Africa, and Lebanon. And I have a variety of COPE CBT-based programs. They're portable, they're manualized, they're structured. Both people who deliver COPE and people who go through it love the structure. As a therapist myself, before COPE, you might spend 3 to 4 sessions just trying to pull teeth to get your people to talk, really talk to you. With COPE, they know what to expect. They come in, the manual's open, and we start. Session 1, session 2, session 3. People really like that. Developmentally tailored versions are available for 7 to 11-year-old children, 12 to 17-year-old teens, 18 to 24-year-old young adults, 25 and older adults, pregnant women. I just finished an NIH-funded clinical trial that showed beautiful drops in depression and anxiety in pregnant, distressed women, cancer survivors, and patients. In fact, City of Hope, which is a fabulous cancer center in the state of California, is started implementing COPE for young adult cancer survivors. I also, a few years ago, adapted COPE for clinicians. That program is called Mind, Body, Strong. I also have a digitalized version of an online COPE program that can be self-administered by teens. So COPE can be provided one-to-one, face-to-face sessions, small group sessions. It's provided in classrooms. Washington, D.C. School District now has about 70 of their people trained to deliver COPE throughout the whole school. Telehealth sessions. I have a lot of people doing COPE now via telehealth. Any type of venue COPE has been delivered in. I was funded 2 years ago by the American Foundation for Suicide Prevention to do a clinical trial. What we're doing in that clinical trial is we have digitalized my CBT-based program. We are randomized 502 nurses across the United States who are participating in this program with mild to moderate to severe suicide ideation. So we are testing the inner screening program by AFSP alone to the interactive screening program plus my CBT-based program. So we are going to know soon, is it better to combine the screen with COPE or to just have the screen alone? We're really excited about that. In primary care in particular, I encourage providers, if parents can sit in the room with the child or the teen or the young adult, let them listen to the sessions, because a lot of parents don't have these skills. They can learn them from sitting in on the sessions with the teen, if they can sit there and not interrupt and answer for the teens. So This is a paper. I believe all of you got it, or you got the reference for it. I published it in the Nurse Practitioner last year. It's open access. It's a nice overview of the program, and it's really important, as I point out in this publication. You've got to present the program with fidelity, meaning you go through it word for word to make sure you're delivering all the key concepts and skills in CBT. And that's why it's important that each client gets a COPE manual. Before you start the 7-week program with people, it's critical to emphasize attendance at all sessions, because each session builds on the last one. So the highlighting of practice, it takes 30 to 66 days to make a behavior change. Well, it takes 30 to 66 days to make a thought change as well. I always say it's nice to schedule 8 weekly sessions, 7 if you had the opportunity to already discuss details about the program. But the first session typically includes an overview of the program, how CBT skills building works, the evidence behind it, and very importantly, a commitment from the client to attend all of the sessions. The COPE manual is provided at that time. I encourage people, get the PHQ 8 or 9 and the GAD 7. Get it after the 4th session is complete. You most always see a beautiful drop in symptoms. And then again, at the end of the 7 sessions, I like to schedule a follow-up visit in 2 to 3 months after the final session, just to once again assess symptoms and reinforce key skills in the program. Billing, if NP, we use the 99214 CPT code or the 99215, depending on how long you spend with the client. COPE 1-to-1 be delivered in 25 to 30 minutes a session. I also have a lot of psych NPs using it within their medication management visits, because sadly, so many positions for psych NPs are turning into just medication prescribers. I have examples of the quick text documentation in the instructor guide that comes to be a COPE trainer. So to become a facilitator, you can do training online at www.cope2thrive.com. It involves listening to about 3.5 of my recorded lectures. You take a post quiz, you submit a practice evaluation on one person that you did at least 3 or 4 sessions of COPE. The license to deliver this is good for 2 years, and it can be reissued. I really get thrilled when I see the number of people who are going through this program now, learning these skills. The comments that I receive from so many parents, so many even adults. This past week, I've had an adult cardiology clinic pick this up. version of COPE that's called Mind, Body, Strong is being implemented now in 33 healthcare systems throughout the country to decrease stress, anxiety, and depression. Physicians, and other clinicians. So my dream is everybody gets these skills. What's more important, especially earlier on, than our children, our teens, our young adults learning these evidence-based CBT skills that they can use for the rest of their lives? So my next dream, I'm going to start a nonprofit 501c3 mental health foundation, specifically to focus on children, teens, and young adults. But my dream is a world that is free from mental health disorders. So with that, I had this fabulous short clip of this little girl. I'll tell you what she is saying because we are having technical problems. She's saying, just do it. Don't let your dreams be dreams. You can do it. You just got to do it. There are so many people who have put their dreams on the back burner. A lot of you have dreams. I want you to put your dreams on the front burner again today. Say, I can do it. Take the risks and move forward. There's so much opportunity there in the world. She says, just do it. Just do it. Yes, you can. Just do it. And I love the ending. It's great. So with that, this is my contact information. And now I'm happy to answer any questions that exist. So hopefully Carly has some questions for me.
Yes, we have some questions already put in, and I invite if anybody else has any questions, write them now. So, Bern, thank you for your presentation this evening. I am so happy to have met you way back in the late 1980s. This is Susan, while we were both in upstate New York. Thank you for your contributions to nursing over all these years and for the COPE program which you are sharing. Could a BSN working on an inpatient psychiatric hospital unit become a facilitator? It is a new hospital and program, and she says they are not offering their patients therapy. Perhaps this program could be an alternative, and could the BSN become a facilitator?
Absolutely. I have several BSN facilitators of COPE, you bet. And we've even had some psychiatric units implement COPE. So that's already being done, which is great because it's hard to believe a psychiatric inpatient unit would not be delivering CBT. I mean, that was where I was how many years ago in upstate New York. But please, yes, you can become a facilitator. You'll be great at it.
Did you say that health coaches can use CPT codes for reimbursement? Please advise.
Fortunately, Karen, your wonderful leader, has been advocating for that like crazy. But I have not seen where that reimbursement for health coaches, but I will tell you, I have several health coaches that are charging cash or credit card to put people through the COPE program. So a lot of people create a very active practice. I mean, I have many people that are doing COPE. Half or full-time, and charging cash or credit for it. So you can do it that way, even though you can't be reimbursed for it.
Out of curiosity, what is the cost of the program?
Yeah, the 7-session COPE training, which can be done online, completely online, is $395 for the 7-session program. The 15-session COPE program that has nutrition and physical activity in it, $165, but that includes, you can also deliver just the 7-session as well.
Okay. Someone said hello and thank you for your presentation. Several years ago, I read some research which suggested that DBT has higher success rates than CBT because it includes the teaching of mindfulness skills. I understand that COPE program includes teaching mindfulness skills. Can you describe any differences in the DBT approach and COPE? Thanks.
Yeah, I think whatever you choose that works is fine. But there's a lot of evidence behind DBT, but CBT clearly has more high quality clinical trials that support, even in the USPSTF, or interpersonal psychotherapy for depression and or anxiety. The nice thing about CBT, it works for both. If you have an anxious client, you have a depressed client. Chances are depression and anxiety will be comorbid. They'll run together. But CBT works for both, which is great.
Someone else said, you are amazing. Thank you for paving the way to help us end the mental health crisis. How would COPE look as part of a holistic nurse coaching program for a BSN RN?
Oh, I think it would be a fabulous addition because it really gives you a tool, a program that is manualized and structured, and you can go through it session by session. Again, you can look up all my publications. There's many publications, not just done by me, but others who have translated COPE to practice, and they documented the outcomes. But it is a single subgroup that it has been tested in. So lots of evidence behind it and CBT.
Fabulous. Any advice on convincing employers to allow us, meaning nurse practitioners, to implement COPE in our clinics?
I would show them the data because data speaks loudly. And if a physician or NP would oversee you, then it could be reimbursed in your clinics, which some places are doing across the country. So I would say take them my 2024 publication that I just talked about. Take them the cost analysis that I did, those two things. Again, there's a lot of physicians that are using the program across the country, and they love it too.
Great. Can we use this for nursing students? Somebody asked.
Oh, bless you for asking that question. I actually have several faculty trained in colleges and schools of nursing throughout the country that are implementing COPE. I have vet schools and pharmacy schools that are implementing it, engineering schools. I think every student coming to college as part of their orientation or their first freshman semester, this should be integrated into one of their courses or a 1 credit course, which some places have done. They need these skills desperately.
Yes, I can see it in all orientation programs when you get your first job at the hospital or you go to college. That's a great. When you purchase the 7-session manual program, does that include the training program? Thank you.
Yes, it does. And it includes 3 code manuals of your choice. So when you go to get the online training, we ask you, which manuals would you like? Child, teen, young adult, adult. I'll be adding the pregnant women, the cancer survivor one. But yes, you get those manuals with the training instructor guide.
Someone asked, what ICD-10s do you typically link with the CPT codes?
Yeah, major depressive disorder, anxiety disorder. Those are probably the 2 most common.
Okay. So is being a COPE facilitator the same as CBT certified?
No, they are not. So to be CBT certified, you would be, say, a nurse practitioner like me that goes on to get, they call this program CBT skills building instead of CBT pure. But if you had a CBT manual and you took the COPE manuals, you could pull out all those key concepts in CBT. But I didn't want to call it pure CBT because, again, you got to be a licensed practitioner to be able to then deliver it. Whereas I wanted teachers in the classroom to deliver this as a preventive and early intervention for their children, their teens, their college students.
Someone asked, is this offered through INCA? And no, the COPE program isn't offered through INCA, but we highly support each other. Right, Dr.
Yeah, we plan on collaborating with each other for sure, because again, it's another tool in your coaching toolbox for sure.
Some people are asking if you can share your contact info slide again.
Yeah, I'm happy to do that.
So we can keep that up there as we talk. So someone's asking, they have a DNP, ACNP, board certified, and recently graduated as an integrative nurse coach. Can I use the CPT code for reimbursing using telehealth?
You should be able to do that. Great that you got that DNP plus the integrative nurse coach. Yeah, I think it's fabulous. Carly, can you see my slide?
I cannot see it right now. Are you sharing?
I thought I shared, but maybe I did not. How about now?
Yep, now I see you sharing. Yep, there we go. I can see the slide. Someone said, thank you so much, Dr. Melnyk, for all your time and talents dedicated to mental health. I feel so much more hope for this world, especially our children. I love your dream and teaching our very young. These skills can prevent many mental health and physical health problems, the whole mind, body, spirit connection. Someone asked, so do you have to have a major depressive anxiety disorder? I guess diagnosis is what they're asking to be reimbursed.
Oh, No, there are others. And if you email me, I can give you some more information about that. If somebody's at risk for whatever reasons, people will get reimbursed on that too. So email me. I'm happy to give you that supplemental info.
Thanks. Does completing the training give the facilitator unlimited access to implement the training without additional cost over the 2 years?
Yes. Now, what a lot of people do is they will either provide the manual, say their hospital, their clinic, their practice, or they ask the person to get the manual from Cope to Thrive. So people do it both ways. But again, it's important that each person that goes through the program has a manual because of the practice that needs to be done after each session. But you can either assume the cost for that, say if you're charging cash or credit, it can include the cost of manuals. Several of the manuals are $25. The longer manual, the 15 session, is $35. So it depends on which one you're going to be delivering to your clients.
Some people are asking about the Mind Body Strong program. Do you know any newly licensed nurse practice transition programs using Mind Body Strong as part of their program?
Yes, I do. And again, if you contact me at my cope.melnyk email, I can share a few of those with you. I have more places contacting me right now about building that in routinely into their residency program. I can
Fabulous.
even share with you the randomized controlled trial that we did with Mind Body Strong that showed beautiful drops in stress, depression, anxiety. But here's a cool thing: increased job satisfaction 6 months after the end of the program.
Awesome. Someone said, I am a CNS as well and want to be able to implement this program. How do I connect with others who started this in schools or within their communities? Can CNS reimburse for this? We do
Yeah,
have PI.
absolutely. And I can connect you with a couple folks. So again, if you email me, I'm happy to do that.
Awesome. And someone asked, I think you already answered this. What is the cost per manual?
$25 for the 7 session child, teen, young adult. The 15 session is $35 because it includes an additional 8 sessions. And I'm blanking, the adult manual may be a little bit more, and Mind Body Strong.
Okay. Well, thank you so much, Dr. Melnyk, for answering everyone's questions. And thank you all so much for joining us tonight on the Integrative Nurse Coach Gathering webinar. So I want to encourage everyone to reflect on how you might bring this, what you learned tonight, to your nursing practice and to your communities. And like Dr. Melnyk said, if you have any other questions or you would like to learn more about implementing COPE or continuing your journey with INCA, please don't hesitate to reach out. And when signing up for the COPE program, please mention INCA at registration in the referral box.
Mhm.
Sending out a follow-up email with all the information. And thank you again to everybody in our community for your commitment to this whole person care, and take care. And we'll see you at the next webinar on May 15th. Thank you
Thank
so
you so much, everybody. Take good care.